Okay, sure. So we'll start in meanwhile. The objective of discussion is what are the global guidelines, what are Indian practices, and what are the barriers, and how can we resolve it. So we agree or disagree, venous access is a very important point for patient and for an oncologist to give a treatment or complete or compliance on treatment is very important if venous access is there. So it may seem minor, but it can dramatically affect a patient's ability to receive appropriate treatment. I've seen patients who are non-compliant just because we have not advised an appropriate venous access device. So these are the data from Western world. 70% patients receiving irritant vesicant chemotherapy experience phlebitis, and 22% patients receiving irritant vesicant chemotherapy experience extravasation. So to each of the panelists, is this same? Do your patients complain as frequently as it is reported in Western world?
Almost same. Some degree of phlebitis is there in almost 80 to 90% of patients, and vesicant therapies, extravasation is also there, of the tune of 3 to 4% with serious extravasation and some degree of irritation up to 20%.
Regarding phlebitis, yes, it is more than 50% of the patient may have phlebitis, but not much of extravasation I have seen, right? 22%, maybe 4-5%.
Absolutely right. So phlebitis is not that much of issue for all of us, but definitely extravasation. We have seen many times patient they develop extravasation, but they are not aware. They go back home and after one week or 2 weeks they come back and say this has happened. So that is a very common thing, especially in breast cancer patients where we give anthracyclines. So that is a very common issue there. So in that case, we have to be definitely aware of these things, and we should counsel also them about this issue.
True. So as across the panel, we can see it again depends on where you are practicing. If you have a lower socioeconomic class of patients, they may not complain only. They feel that this is the usual thing which will be there. So it is not patients who are reporting, so we may not appreciate the 70% phlebitis rate. Extravasation is 22%, but these are all the grades of extravasation. Many of our patients, Indian patients, are really tolerable in such situations. They don't report only. And we are too busy to ask also. So what are the global guidelines? So a brief where you would ask for PICC, where you would ask for port, or where you would ask for tunneled catheters. Sunil?
So for patients requiring long-term infusions of chemotherapy, and the duration of chemotherapy maybe is lasting for 3 months, 6 months, or up to a year, I would advise a PICC catheter. Port, maybe in the cases like breast cancer where we require a long maintenance with trastuzumab, there I use port.
Any other opinion from either of the panelists?
So similar, pediatric patients more tolerant to PICC line rather than a port. Very difficult to find pediatric surgeons who would do port. And adjuvant colon, I prefer PICC line because it's easier, 6 months of treatment and every 2 weeks they are coming. So this is the same experience.
Right. Hematological malignancies like AML, we usually prefer PICC before. So basically, with more and more maintenance therapy, we are giving more and more patients are having like long PFS on our maintenance therapy. They need long-term therapies, continuous therapy. In that case also, to just for a patient comfort, we can consider PSC insertion, like even maintenance, like we are talking about maintenance immunotherapy, even in pemetrexed, sometimes patient pemetrexed maintenance for maybe 2-3 years also. In that case also, you can consider PSC insertion.
Yeah. So largely PICC would be considered when it is up to 6 months or so. That is what everyone wants to say. Okay. So when complications are so common with routine IVs which we took in peripheral means, we should ensure that patient receiving the irritants and vesicants should be started on central line. So these are the time points or these are the points which we decide on. So type of chemotherapy, as you all told that for 5FU infusion, we will prefer some form of vascular access device for duration of treatment, indwelling time. Beyond 6 months, people are not comfortable with PICC, as what I can see. Based on patient's vascular access availabilities, again, important thing, patient appropriateness is very important thing in our setting. So a patient coming from periphery, I have faced n number of challenges when someone with in periphery is sent with PICC. Is that the same situation? So do you decide PICC versus port based on from where patient is coming?
So sir, it is true when the patients are from periphery or maybe some those who do not understand the like PICC care, it is very tough to manage PICC. Sometimes they don't they don't do dressing. The PICC is in place for weeks, like till the next cycle of chemotherapy. So it becomes difficult. So I try to guide them. I try to teach them how can they do it, or also they can approach some local physician and they can take advice how can it be done.
Any other experience to share?
When there is a patient who comes from periphery, I always see which is the nearest center where he will take treatment. So if the nearest center, I speak to the oncologist, if he has an access to 24/7 surgeon, in case of infection who can remove the port at night, I suggest port. Otherwise, PICC line is what I prefer in those patients, because in case of a center line, infection, it's very difficult to get a surgeon who would do a port removal at night. And these patients may actually require some urgent intervention. So PICC line in those patients where there is not availability of a surgeon, or a center where surgeon will not be able to take care of it.
So, Dr. Samir, how common have you seen patients coming with PICC without stitch, without dressing, with pus? You can see at the insertion site.
So not very often, because we have a good nursing team with us. So they consult them properly about the PICC care. So that is very important. The nursing care is very important. How use the nursing staff, how they consult the patient, and how much patient is educated and how much he understands the importance of the PICC care. So that is really very important, how you choose your patient. But in a case where patient is not that much, he has not that much understanding of the PICC care, and the nursing staff also don't consult. So this can always happen. So we should be careful about that.
So this is an important point, that nursing staff or PICC care clinic is taken care of by some paramedical staff. But unfortunately, when you are practicing outside institute, then it is really difficult. You see PICC nurses changing every 3rd month, 4th month. It is very difficult to sensitize them only. And then to sensitize patient is the next challenge.
You can have a video and you can just share the video with them to how to take care of PICC.
So I will just tell you that I had shared a video. Patient went to a nearby physician, but he was not ready to do. He was not comfortable to do. So when you do it practically, you will face newer and newer challenges. So for vasi content irritants, do you do some form of vascular access device in all the patients?
We tend to suggest, especially if they don't have a good vein, and we try to recommend them to do it.
And do you take samples, blood samples from the vascular access device in routinely to cut short on pricks?
Yeah, routinely. For colon patients where I am not contemplating to delay Folfox because of borderline count, I tell them to do it in the hospital only.
True. So that also helps, that comforts the patient. So this is just a hypothetical case that if a patient has taken 2 or 3 lines of treatment, even in lung cancer, if you calculate, there will be more than 50 pricks in a year. So this is something which we never consider while we are treating the patient.
So sometimes the cost of drug is so high that if you don't get the any time, central line can be one time.
Yeah.
For immunotherapy, the patient is going to be on maintenance. You have to give this option to the patient. One of my orthopedic friend, in fact, called me, Bharat, I want to put a PICC line for my ortho patient. So this is very important for immunotherapy drugs which are going to be more than a year. You have to discuss this option. When we know that there is no when we see. It's your clinical examination part is to find a vein.
Yeah. So even if when you see the veins, if patient is taking treatment beyond a year, it is a good idea to have some form of vascular access device. So in solid malignancies, will you prefer to put PICC. Breast, most of us do some form of vascular access device. Port is frequently done. But would you do PICC for a lung cancer patient, ovarian cancer patient, or a breast cancer patient?
Any patient where we think a patient will require a long-term continuous IV therapy. In that case, you can consider.
I would choose port over PICC.
Yeah, Vijay also want to have some.
Okay, why not Portman?
I have chosen
So-
port. Sir.
So,
I have
what-
chosen port only. Yeah. Port was
Port is also one of the option, no doubt in that. But port is more invasive, it is more costly, and even many times nurses at every place are not trained with port handling. So that is sometimes
so
Lakh rupees. That's a big challenge.
yeah, so port, the main issue is the cost. Sometimes it is as costly as the breast surgery.
most of the times patient may not be ready to have a PICC for a period of 1 year. So it's better to choose port.
So you have to give, probably you have to give both the options to the patient in most of the situations. As all of you told that if it is like 3 months or 2 cycles of TPF, then probably PICC is good enough. When you are considering for a longer time, because PICC maintenance is also a challenge, it is not very easy to do. Beyond 6 months, there are data to show that beyond 6 months it can be used very easily. But in private practice, when patient is from periphery, it is a challenge to preserve PICC beyond 6 months.
basically colon adjuvant, whatever colon, that's the most common place.
Yeah.
See, the thing is that if you are doing, Shivam has suggested, your ideal way of PICC dressing flushing once a week, then PICC like a EMI, while port is on a one-time purchase.
But it's
Does it cost that much?
port.
Hospital and find out how much PICC training costs. It's not less than 1,000 rupees, 1,000 to 2,000. If I am doing ideal way once a week at least dressing flushing. So usually
I'll
all-
share. I'm using only twice a week dressing, sir.
all my metastatic patient port. There is no option for PICC. All my metastatic patients, curative patients, anything less than 3 months, like or I'm especially head and neck where I'm using DCF kind of regimen, then I use PICC. Hemat patients, it's patient per patient basis, so most likely it will be PICCs in leukemias, while or Hickman's if at all, and lymphomas will be port if at all I'm using.
So we have data from guidelines that you can keep PICC even beyond 12 months. But as we all discussed, it is challenging to maintain when you are not in a setup where you have a good nursing staff, good PICC team who take care. You just need to mention PICC care and maintenance. When you do it out of your clinical time, then it is a challenge. Maintaining port is much easier. So a brief, what is PICC means, how are you maintaining PICC at your center? Is it done by nurse? It is done by USG guided? Is it done by anesthetist?
So, all the 3 methods I am using, in one setup nurses are doing. Somewhere I use, I take help of intervention radiologist, and I am also putting PICCs to patients who cannot afford this procedure outside center.
And I'm doing twice a week flushing. So it's syncing with the chemotherapy
I
side.
think Samir has PICC setup at his center. So
Our
that
insertion
is
is
not
done by anesthetist, and the
Okay.
care is done by nurse.
Okay, okay. So that is the ideal way you can cut down cost when nurse is able to put it and maintain it. And USG guided is something which is very feasible. So there are different type of PICC, open or closed, single, double, triple lumens, valved and non-valved. So is there anything specific you look when you are prescribing PICC?
So closed PICC means walled PICC doesn't require heparin flushing. That is the most important benefit of that. So I always prefer that.
What is dressing and care recommendations given by you, Dr. Shivam?
Sir, again, I'm not using weekly flushing. I'm using 2 weekly or 3 weekly flushing. Not out of 100, maybe 1 or 2 blockages.
Okay, that is good. So
Weekly flushing and dressing.
I too still push for weekly flushing and dressing. So what is the rough percentage of premature removal? A ballpark figure from anywhere. Okay. which is really good. If it is less than 5%, I've still not reached there. So now there are teams who can come home and do PICC maintenance. Again, don't ask me the cost. It comes with a cost, but that is something which is available. Patient is not supposed to visit the hospital. They can go home and do the maintenance work. So in Ahmedabad, it is around 2,500 to 3,000 per visit. Flushing and dressing, whatever is due at that point of
That is
time.
home.
They will come to home.
So I will tell you where I was trained for my transplant. So that time, if I think old timers will remember, there is something called Cavafix used to come, be around 375, 475. And we used to put Cavafix, which used to cost some 400, 500 rupees. And we used to have like trained nurses. And we also presented a data in EBMT that we manage entire transplants and we kept these PICCs almost for more than 1.5 years. So there was data and it used to cost 400 rupees that time. But see, that requires a totally dedicated team. And again, I will say that all these long, PICCs, I think the rate of thrombosis we have to look at, especially when you are using in a metastatic setting and all other settings where uncontrolled disease.
So, care maintenance is not as easy as what we see in institutes where it has been established, and complications rate are real. It is not like it is just a theoretical complication. So once you are putting any vascular access device, port infections is also a trouble. It is not very easy to manage. I think so. Thank you all the panelists.
Chalo. Thank you. Thank you, Rushabh, and thank you all the panelists. Now I'd like to invite Dr. Akhil Kapoor. He's a consultant medical oncologist at Varanasi. It is time to raise the bar for ALK positive NSCLC. Over to Dr. Akhil.
Yes, thank you. So I would like to invite the panelists, Vijay Patil sir, Dr. Chandrakant sir, Dr. Piyush Bajpayee, are you here? I don't see him. हाँ हाँ आ रहे सर. उल्लास सर अब भी yes. Yeah, that will be good, no? So let's start with the disclaimer. So we have seen ALK inhibitor development timelines. 2007 there was the first discovery, and later on we have come up a big way. Crisalk got approved in 2012. Now we have just recently published our own data of utilization of ALK inhibitor in our practice. Out of 441 patients, 86% could receive ALK inhibitor, and at least first, not in always in first, but in second line or third line. 66% could receive in the first line. We will be discussing lorlatinib, but yes, adhering to the groundwork is also important. That is why I started with the ground reality.
No, Akhil, can I ask you a question?
Yes.
Out of this, over the years, did the usage change?
Yes.
So, maybe in 2014, 2015, people were giving, chemos initially and then giving this. So, over the years, has the percentage increased?
Yes, definitely. Percentages gradually changed. And this data we restricted to the analysis till 2018 because we wanted to have at least 3 years mature data. That is why this data is till 2018. After that, we have added at least 300 more patients. So we have now database of 750 patients.
And this data has got ALK by IHC or by FISH?
Yeah, till 2016, we were using IHC and FISH. But later on, we shifted to IHC alone.
This also will play a huge role because
Yes.
ALK, IHC, FISH will take a lot of time to come.
Yes,
So by that time, you would have started chemotherapy and then.
Correct. We have also published our data and presented at WCLC about discordant ALK, IHC and FISH. Yes, sir.
In fact, Dr. Ananta Ramaswamy, I think it was 2014, he has published the first paper of, and that time this rate was much less. It was 60.
Yes. At that time, the database was of 98 patients, and percentage utilization was 76. Now we have moved to 86%. So at least 10% improvement in utilization also. So definitely, that is the ground reality which we are seeing. So let's move ahead. We now that with the availability of more and more data and trials, now the lorlatinib is an approved first-line option in 2021. So is there an unmet need in ALK positive NSCLC? Yes, there is. Let's see how it is. we know that conventionally it is non-smoker, light smokers, but I'm not going to all this. But CNS mets is an important point that occurs in 20 to 40%. So, Dr. Piyush, in your practice, if you are getting a baseline metastatic patient at brain mets, how do you select the treatment in your practice? ALK positive, NSCLC, metastatic, brain mets. First question, whether you are using brain radiation or not. Second question, you are selecting selection of TKI.
And yes, of course, I mean, depending on how the patient can go for it, lorlatinib is, a discussion, alectinib is a discussion.
Yeah.
Yes.
Okay, okay. Chandrakant sir, moving to you. Are you doing L-kinase domain testing in your patients who have progressed on first or second generation TKIs?
No.
No. Okay.
Rebiopsy and look for the resistant
Yes, repeat
mutation.
biopsy and testing for kinase
No,
domain.
not doing. If I'm going for lorlatinib, I would not anyways do.
Yeah.
So if the
With
patient is
lorlatinib
not-
definitely not required because we know nothing after that is available
So
till
up to
now.
now, I've not done a mutation rebiopsy for ALK.
Vijay sir, your preference?
Choose or
Yes.
which also, so things is, my preference here is if the patient has brain metastasis, my choice goes to lorlatinib. If the patient doesn't have brain metastasis, I'm actually happy with alectinib.
Okay, so I would want to say brain mets, asymptomatic, a number of brain mets, the size and whether you know how much are there. If there's one big brain met which is causing symptom, maybe more than 3 centimeter, and ask my surgeon to take it out and they take it from there, or maybe give radiation if it's less than 3 centimeter. But we have very aggressive neurosurgical department, and also because I want to do a study in which we are looking at a discordant rate of brain mets versus this. So the first thing goes to surgeon.
Okay.
One. If it is asymptomatic, and if it is asymptomatic and bilateral scattered patient not symptom, I would rather go to lorlatinib. No doubts about it now.
Okay. So at least
We do a rebiopsy. Just now we have got a patient who has got alectinib, and after alectinib, the patient had a L1196I mutation sensitive to serotonin. And that has now given me 8-9 months.
Yeah.
So I told the patient, see, lorlatinib to kabhi bhi le loge. And I know it's a Pfizer symposium, but then it's okay. But then we got serotonin, and then we are going to give lorlatinib after that.
Yes.
Got a MET.
You have got a MET
mutation
mutation.
post lorlatinib.
Yes.
And yes, with after lorlatinib,
post
lot of MET is
lorlatinib
coming up.
and-
Post Lorla also we have an option. So, yes, sir.
So what is your experience with leptomeningeal mets? So when initially we never used to have brain mets clinic, since we have started using a dedicated brain mets clinic, our radiologists have started bringing a lot more of leptomeningeal mets in this
There are
driver
two
mutation.
things. Leptomeningeal mets are more common with EGFR. With EGFR, you will have a 10 to 12% chance of brain mets plus LM mets. With ALK, LM mets actually are not that common. But both these alectinib and lorlatinib is a sweetheart as far as the brain mets.
I
is
also
concerned.
completely agree that leptomeningeal mets are much more common in EGFR, but much rare in ALK. And in our database also, we found very less incidence of leptomeningeal.
We had 2 patients with leptomeningeal mets.
It's
Both of them
candidate.
we gave lorla. So I think both of them had a good response.
What
so
we also
I mean, we never see a response, such a good response with any TKI.
Yeah.
And lorla is something very unique to get such
One
responses.
also thing that we have done, not for this discussion, we do CSF, and if sometimes the M cells are not positive, we do a RT-PCR for EGFR on that. And we actually picked up T790M in that. I've got around 30-35 patients now in which CSF it has come positive on for publication.
So yeah, we do that also, CSF cytology and CSF cell block as well. We
CSF,
RT-PCR directly. So even we prepare CSF cell block, and on that also we can do RT-PCR. That is also an option. So this is the crown data. I think now everyone is aware of that. Nothing new to it. It's like a historical data already to us. But just to highlight a few important points, there was a stratification for brain metastasis and ethnicity, and 100 milligram versus Crizo 250 milligram with primary endpoint of PFS. And if we see the data, you can clearly see it's as expected. Lorla is doing much better than Crizo as expected. Even 3 years data, you can see 18.9% versus 63%. And after 3 years also, you see that it seems that there is significantly maintained response, but there might be some significant dropout rates. If we see that baseline brain mets, again, Lorla is scoring much better than Crizo. And without brain mets, again, there is a maintained difference. If we see such analysis where everything is towards the left, I don't think there is much more to say, and we are very happy to utilize the drug in overall. Now, if we compare this data of Crown, Alta-1 and Alex, anything, sir, Vijay sir, you would like to highlight anything on this data?
Good idea. But if you look at the hazard ratios is 0.27 for Crown. For the rest, the hazard ratios are 0.5. So proportionally seems to be a better drug, at least for cost trial comparisons. But and in fact, there is, if I'm not mistaken, in 2022, I read there's a meta-analysis which is comparing all three, and that actually shows that in that meta-analysis, it did show that Lorla seems to have better hazard ratios both with respect to alectinib and brigatinib.
Yes. This is another data which I wanted to highlight and found that intracranial time to progression in patients without brain metastasis, it's constantly 99% for over 3 years. That is also very important to us, and it's because we know that though patients not having brain mets, but still brain is the most common site of progression in these patients. Sir, do you agree? Your experience, sir?
Yeah. So I think baseline you will have 26-27% people who will get brain mets. Over a period of time, if you live there for 5, 6, 7 years without lorlatinib, at least it will become 60-70%. So brain has to be addressed. I mean, we have a protocol in which we do PET and MRI brain for everybody.
Yeah.
So MRI brain has to be done at every time. A small mets come, you give RT to that and then continue on to that. So that is how
Otherwise, there might be deterioration in PS. That is very important because if patient deteriorates, it is very difficult to salvage. Yes, sir.
And just out of when Dr. Batra was telling, sometimes this single meds which come in ALK are quite peculiar. They actually seem to be similar to neurocystic sarcosis. In fact, there are the cystic lesions, cystic brain mets. In fact, there was a huge discussion which we had in brain mets clinic, Colex hai kya, ye hai kya, and when we subsequently saw it, actually turned out to be a ALK positive brain mets. Yeah. So we need to be careful in such patients, and I agree with him. You need to do a MRI before putting this patient. Sometimes the patient is asymptomatic, you don't do a MRI. Patients become symptomatic, you do a brain imaging, and then your radiologist say, oh, the brain mets have started sclerosing, and you don't know whether this is post-treatment or...
But I'll tell you one, just go back one previous slide, Akhil, just one more, the 99% wala slide. In fact, the way Pfizer is positioning it right now, if the patient at baseline does not have brain mets, and you give lorlatinib, at 3 years, there's only a 1% chance that you will get a brain met. So in people who do not have brain mets, you can actually afford not to do an MRI brain. See, right now, hamare yahan to MRI brain
with that curve, I won't say, if you see the censoring, a lot of patients have got censored within 2 years and 3 years. Right. So if there was, that censoring was not there, and if it was after 3 years, I think we would have said that, but that amount of censoring, I think that would be a message we want to give.
But sir, I think censoring will be part and parcel of such studies. We cannot avoid it. Yes. So since time is very limited, I will just come to final comment. Any experience of neurotoxicity in such patients? Anyone?
So we had part of the 40-50 people of lorlatinib. The drug is good. The issue is you have to tell your patient that listen, 3 side effects honge hi honge. Ek, your cholesterol will increase. Yes. On a day 15, please do a lipid profile. Tell them rosuvastatin lena hai. That is one. Second is a weight gain that I have been seeing. People have got around 20 kgs of weight increase. That is one. The neurocognitive side effect is something which you, if you don't ask, you will not get. Because you don't ask. So you have to tell them कि थोड़ा mood change हो सकते हैं, थोड़ा depression हो सकता है. And people, it's not as severe over there, but you need to talk to them.
Yeah.
So these are the 3, and hypertension, hyperglycemia are 2 more side effects which are now coming up. But I mean, if you are forewarned, it's reasonably okay.
Even hallucinations are something like a couple of my patients have reported hallucinations.
Okay.
Also, pedal edema is one particular thing that pedal.
And we should avoid it giving along with the radiation. So if you give it, probably the psychosis is more. That's one.
So that was one of my major concerns. One patient on crizotinib PD, lorlatinib radiation दिया था, lorlatinib दिया था. अब वो patient came to us in an absolute acute psychotic state. We did not know whether it was because of the brain meds or whether it was because of lorlatinib. So gave some steroids दिया तो वो psychosis हो गया. Stopped lorlatinib, did that, changed over something else. But yeah, the neuropsychiatric manifestations. See, as oncologists, we need to know. I always tell the younger residents, you know, it is not gefitinib, imatinib. And even gefitinib, imatinib have got side effects. You do LFT with gefitinib, you will find out 5% of people will have LFTs.
It's very common to have lipid derangement. Yes,
People don't do.
So it is the off-target NTRK sort of inhibition that basically causes this neuropsychiatric manifestation.
So just to highlight, this was the meta-analysis which Vijay sir was highlighting, and in this data it is clearly showing that it is a significant benefit, and it concluded that lorlatinib was the best treatment choice for these patients who were either ALK inhibitor naive or untreated ALK positive advanced cells. With this, I would like to stop here. Resistant patterns, I think we cannot take up due to shortage of time. Thank you.